started and that expanding access to modern contraception is critical to the prevention of unplanned pregnancy and unsafe abortion. Thus, the public health rationale for preventing unsafe abortion is clear and unambiguous. For PAC implementation, it's really critical to ensure that all stakeholders at the global level as well as at the country level have a solid understanding of the legal indications for abortion in their country setting, so that in addition to PAC being offered in all cases, quality, comprehensive abortion services are available for those legal restrictions. The Center for Reproductive Rights has been mapping the world's abortion laws since 1998. And these next few slides we'll see the change in some of those abortion laws. So here we see the abortion laws in the year 2000, and then we'll see abortion laws as they changed in 2007, and then now in 2014. And again, I encourage you to look at some of these maps where you can really see where the changes have taken place. So since adoption of the ICPD Program of Action in 1994, more than 30 countries around the globe, including more than a dozen in Africa, have liberalized their abortion laws by enumerating additional legal indications for abortion. During this same period, only a few countries have placed further restrictions. Governments are increasingly recognizing that restricting abortion laws only cause women to resort to unsafe abortion, while increasing the legality of abortion is a key step towards realizing women's fundamental human right to health. While liberalizing sexual and reproductive health and abortion laws is certainly a critical step towards increasing women's access to comprehensive care, we know that laws do not equate with access and quality service delivery. Barriers remain and need to be addressed. We're now going to look at global safe and unsafe abortion trends over the past 20 years and what they tell us about the state of post-abortion care and unsafe abortion, and the priority areas to address in order to ultimately eliminate unsafe abortion. And I'm going to turn the presentation over to Catherine Turner.
Is that definitely on? Great, thank you, Maureen. So the following slides on global abortion and PAC trends were generously provided by Gilda Sedge of Guttmacher Institute, and they represent a compilation of findings from Guttmacher and WHO research projects, as well as a comparison with other related findings. And the goal of this work was to estimate how many abortions are taking place in the world and to assess trends in abortion incidence in 1995, 2003, and 2008. The only times thus far that global abortion incidence has been estimated, although I'll tell you a little later about upcoming estimates. Abortion rates were then compared between settings where laws are liberal versus restrictive. So let's look at some of these results. In 1995, the abortion rates were estimated to be about 35 abortions for every 1,000 women of reproductive age. This means that roughly 3.5% of women of reproductive age had an abortion in that year. Of course, this isn't an exact correspondence because some women have more than one abortion in that year. The abortion rate was higher in more developed countries than in developing countries in 1995. But by 2003, the abortion rate fell. It fell more sharply in the more developed world, making the abortion rate lower in more developed countries than in developing countries. The sharp decline in the more developed world was driven largely by trends in Eastern Europe at that time. Then the abortion rate between 2003 and 2008 remained largely unchanged. One of the ways in which Guttmacher examined their findings in the context of other research was to compare the global trends in abortion with trends in contraceptive use, estimated by the United Nations Statistical Division. The green line is the global abortion trend that you've already seen. The blue line is contraceptive prevalence. The UN has made estimates of contraceptive use going back further in time, and you can see that contraceptive use was increasing for a long time and then began to plateau during roughly the same interval when abortion incidence was also stalling. Between 1995 and 2003, the decline was primarily in the rate of safe abortion. By 2008, there was little or no change. The small change was in the safe abortion rate. Overall, the rate of unsafe abortion has not declined since 1995. We do believe, though, that the severity of unsafe abortions may be declining with time. Using these global data, Guttmacher estimated the proportion of all abortions that are unsafe in the world's regions. Almost all abortions in Africa were determined to be unsafe. Essentially, all abortions in North America were determined to be safe. The unsafe abortions in Europe were concentrated in Eastern Europe. We'll visit the issue of defining unsafe abortion a little later in the presentation. After they made estimates of the levels of abortion, Guttmacher compared abortion rates where laws are liberal with rates where laws are restrictive. We see that abortion rates are lower in subregions with liberal abortion laws. So this really belies a common myth that liberalizing the law will lead to an increase in abortion. In fact, it's the opposite. Abortion law reforms have been followed by declines in abortion-related deaths and complications, as illustrated in these country examples of South Africa, Nepal, and Ethiopia. Most legal abortions are safe, which is why liberalizing abortion laws is a critical step in eliminating unsafe abortion. Other research has demonstrated some of the consequences of unsafe abortion. The WHO has estimated that even while the global maternal mortality rate has been declining, 13% of all deaths are still due to unsafe abortion. And each year, millions of women experience complications from unsafe abortion, and almost half of them don't get the medical care that they need, which is why we're here. Guttmacher is developing new global estimates in the next 6 months, which will take into account the changes in the definition of unsafe abortion. So we'll no longer be talking about simply a safe-unsafe dichotomy in which illegal was equated with unsafe. The new estimates will include more subtle distinctions. And I invite you to contact Gilda Sedge at Guttmacher Institute with questions about these and future analyses. And again, I want to thank her for her generous contribution of her slides and technical expertise that she wasn't able to be here in person. This next slide shows the estimated annual number of PAC admissions, the percentage of PAC admissions with moderate or severe complications, and the percentage of PAC cases in which women presented in the second trimester or with the uterine size of a second trimester pregnancy. These figures are drawn from abortion magnitude studies in Cambodia, Ethiopia, Malawi, and Kenya. Note the large percentage of severe cases and second trimester abortion cases. It's truly striking and really deserves our attention. There are also South Africa studies from 1994 and 2004 that show a reduction in abortion-related maternal mortality. Cambodia conducted another study in 2012, the results of which are currently in press, and we'll be glad to share those when they're available. Another magnitude study is currently underway in Ethiopia, and this gives us an opportunity to compare from the earlier magnitude study to the more recent one, and we expect to see positive changes in those figures. I'd like to acknowledge Janie Benson, Vice President of Research and Evaluation at IPAS, and her team for generously providing these analyses for our presentation. In this next slide, we see decreases in the case fatality rates of unsafe abortion in every region. One can see the trends, even if WHO recommends against directly comparing the numbers. We expect to see even more declines with the next set of estimates. Some of these fatality declines may be due to better provision of PAC, as well as comprehensive abortion care, including contraceptive services and other interventions. And while we applaud the decrease in morbidity, just one death is too many. Women should be able to safely end an unwanted pregnancy without fear of death or severe complications. And again, our ultimate aim is the elimination of unsafe abortion. Despite overall decreases in abortion since 1995 and in abortion-related maternal mortality, unsafe abortion persists. Who are the women who are dying from unsafe abortion? Additional analyses by the WHO and Guttmacher Institute, not shown here, demonstrate that it is young, rural, and poor women who are disproportionately dying and suffering complications. Women who have less power, means, and access to care and are particularly vulnerable to abortion stigma. These disparities highlight a blatant disregard for young, rural, and poor women's right to high-quality care. We will not eliminate unsafe abortion until we've ensured equitable access to care for all women. Earlier, we saw the PAC Consortium's essential elements of PAC model that Maureen walked us through. And here you see IPAS's model of comprehensive abortion care, an approach to abortion services that takes into account a woman's individual physical and emotional health needs and circumstances and ability to access care. The comprehensive abortion care model includes induced abortion, treatment of incomplete, missed, or unsafe abortion, or PAC, compassionate counseling, contraceptive services, related sexual and reproductive health services provided on-site or via referrals to accessible facilities, and community service provider partnerships. As we'll hear from country presentations that follow ours, even when comprehensive abortion care is being provided, there is a continuing need for PAC, for miscarriage management and treatment of complications from unsafe abortion that women may resort to due to stigma or other barriers to accessing comprehensive abortion care. Therefore, PAC is integrated into the comprehensive abortion care model. Nearly every country in the world has one or more legal indications for abortion. PAC programs can be made comprehensive by ensuring that stakeholders are knowledgeable about the legal and policy indications for abortion and that services are made available to all women, including young, rural, and poor women for those indications. Sensitizing key local stakeholders using values clarification, attitude transformation, and other interventions to address and mitigate stigma and secure political commitment. Addressing stigma and discrimination outright, and strengthening health system capacity, ensuring the availability of equipment and drugs to expand access points and shift PAC to lower levels of the health system and into the community and ultimately into women's hands. Engaging community members to advocate for the availability of services for those legal indications in that country. Even in countries with favorable laws that are already implementing comprehensive programs, U.S. policies like the Helms Amendment and related funding restrictions limit agencies to a PAC-only focus and divide service delivery systems between PAC and CAC, which strains limited resources and exacerbates abortion stigma by singling out abortion care. These policy and funding restrictions hamper global progress and deny women their right to care. Even in a country like Ethiopia that provides an excellent example of shifting from PAC to comprehensive abortion care, there is a continuing need for PAC. And I'll just walk us through some of the milestones that occurred in Ethiopia, which is the reform of the abortion law in 2005, and then the publication of National Clinical Standards and Guidelines on Comprehensive Abortion Care in 2006. Then there was a National Health Facility Study of abortion incidence and complications morbidity in public, private, and NGO sectors that was conducted in 2007 and 2008 and published in 2010. The national rollout of safe abortion in the public sector by the Ministry of Health since then to the present, and a strong uptake of medical abortion down to the primary level of the health system, provider training and services, and the provision of second trimester services in select hospitals as well. And as I mentioned, a repeat of the National Health Facility Study of abortion mortality is underway currently and will be compared with the 2007-8 findings, which will be released in mid-2015. So here we see a really striking slide that shows the reduction in demand for post-abortion care that has occurred over the time of this implementation of comprehensive abortion care in Ethiopia. The concurrent rise in the provision of safe induced abortion care as a proportion of all abortion care indicates, we believe, that more women are learning about and able to access safe abortion care, and thus fewer women are needing treatment for complications of unsafe abortion, which of course is exactly what we're hoping to achieve. Our data also indicate that more women are seeking abortion at an earlier stage of pregnancy when it's safest. The thinking, as I mentioned earlier, around the definition and measurement of unsafe abortion is continuing to evolve. So I believe we're all familiar with the WHO, the original definition of unsafe abortion that was first issued in 1992. And in their 2014 bulletin, the WHO said, the person's skills and medical standards considered safe in the provision of abortion are different for medical and surgical abortion and also depend on the duration of the pregnancy. What is considered safe should be interpreted in line with current WHO technical and policy guidance. So it's not that the definition has changed necessarily, but that we're needing to link to whatever the current technical or clinical guidance are, and that this will be evolving as technology and service delivery skills and standards advance. There's an expert group on abortion measurement that's been meeting, and the WHO will be publishing another article on defining and measuring abortion soon. So this is really something that is evolving and will continue to evolve over time and will affect abortion data. As I mentioned, Guttmacher will be coming out with updated abortion incidents and reflecting these updated measurements. So for unsafe abortion to finally be eliminated, the sexual reproductive health and rights community and women's and maternal health initiatives must fully address and integrate PAC and abortion care. We invite your thoughts about how PAC fits within broader women's sexual and reproductive health and rights frameworks and initiatives and the growing abortion advocacy movement and the role of the PAC Consortium. I think we've really seen a change over time and, again, a growing global movement to advocate for comprehensive abortion care, but also thinking about how PAC fits into women's and maternal health initiatives. So we've presented here a brief retrospective and state of unsafe and safe abortion in PAC over the past 20 years. We've seen that despite declines in overall abortion worldwide, unsafe abortion persists. So to eliminate unsafe abortion, we must address and eliminate abortion stigma, align human rights and public health, and implement abortion legal and policy indications in every setting. We need to eliminate discrimination and provide respectful care for all women, regardless of their reasons for seeking PAC services, and link with efforts to promote respectful care for women in labor, delivery, and other maternal health services, fulfill women's demand for contraceptive services, and break down other service delivery and access barriers. As we break down the barriers and ensure high-quality care for all women, we want to know about your vision for the future. We envision a future in which there is universal access to high-quality care, that all women can access reproductive health, including contraceptive services, to prevent unwanted pregnancy, that all women can access comprehensive abortion care when they have an unwanted pregnancy, that all women have equitable access to high-quality induced abortion care where and when they need it. When they need it, all women can access treatment to manage inevitable or incomplete abortion and rare complications from safe abortion care. That women are offered respectful care by providers, family, and community for all of their sexual reproductive health needs. That we integrate and scale up PAC and abortion in broader women's, maternal, and global health initiatives where they rightly belong. To effect broader change, we need to engage more and diverse audiences in our efforts, including faith and diverse thought leaders. We're creating a social change movement to uphold women's rights, human rights, and women's right to self-determination. So now and throughout today's meeting, we invite you to articulate your vision for the future of PAC and how the PAC Consortium can contribute to the contribute to the global social movement to eliminate abortion stigma and ultimately eliminate unsafe abortion. So please share your thoughts with us. Those participating virtually can send your comments via the text box or during the question and answer session. And those participating in person, of course, are welcome to share their comments and questions as well as your ideas this afternoon during our discussions. So together, let's eliminate unsafe abortion.
Thank you very much, Kat and Maureen. Because we started a little late, I think it may take maybe one or two questions of clarification, if any, and then we will move to the next presentation. I'm afraid it's going to be very late in Nepal when we ask you to present. So do we have any clarification questions or very, very burning? And please, I would ask you to introduce yourself.
Juge, what works association?
Can you take for people who are on the phone? Thank you so much.
Juge, what works association? Are there any examples of sort of know your rights campaigns about access to legal abortion and what those parameters are for women themselves as well as for providers. And a question of how both of you see moving forward on access to post-abortion abortion care services for women under the age of 18, particularly where in legal settings where even access to contraception is challenging.
So those are two great questions. The first is really focusing on legal literacy, and IPAS and many other agencies, I'm sure, have initiated interventions with health systems personnel as well as with women and community members about what the laws say in the country, what women's rights are to safe abortion care, as well as providers' rights to provide comprehensive abortion care. And I can think of when I was in Ethiopia, there were community health workers who were going around from village to village educating people in Amharic or whatever language in that region about the law and what the legal indications were and where to go for safe services. And so that legal literacy or legal education about legal indications and rights is incredibly important. In Mexico, I know, and perhaps Patricio during his presentation will address that, but many examples around the world of educating from policymakers. Even oftentimes it's really the first step when we go to intervene in a country is that even policymakers are often not aware of their own abortion law, what the law actually says, and then working with local lawyers to really understand how the law can be interpreted broadly to really ensure a broad delivery of comprehensive abortion care. And your point about young women is also incredibly important in that we know that not only is abortion stigmatized, but young people's sexuality in general is very stigmatized. So the fact that young people are sexually active, that they become pregnant, often we're really needing to look at issues of marriage more so even than chronological age, and that a person's marital status has a huge impact on their ability to access care and providers' willingness to provide care to them. So really we have a whole concerted effort at IPAS, a youth program that cuts across all of our technical areas and programmatic areas to conduct values clarification. We've adapted our values clarification attitude transformation materials to specifically address abortion for young women and do those interventions with, again, health systems personnel as well as community members on young women's right to contraceptive services as well as comprehensive abortion care. But a lot more is needing to be done, and as we've seen, young women bear the burden of a disproportionate burden of unsafe abortions and mortalities due to unsafe abortion, and so we really have a lot more work to do to make sure that young women are able to access care equally to adult women.
I think the only thing I would add is just encouraging all of us, the organizations represented here and online, in the countries where we're working, to really engage in this sort of the literacy around sexual and reproductive health and rights and what they actually looks like in the country context and really what can be done to really advance it. Because I think where the sort of rubber hits the road often is in the countries, and I think those of us who really work in countries and have strong country leaders, I mean, that's where the kind of reform and really breaking down the barriers is going to happen. So that's just something that I would really encourage, and I think there's great resources, and we're going to be really hearing about them today and how some countries really have implemented and have been able to really move forward expanded access.
Thank you. Do we have any? Yes, I think we will just move forward, and we have more time for questions and answers after the second presentation. So let's move forward to the second presentation, which is on rights-based policies to address stigma and unsafe abortion. And thank you again, Kat and Maureen. I said already. Thank you. All right, so this presentation is going to be given by Ms. Zia Gali from IPAS. She's Senior Regional Policy Advisor at IPAS, and I understand she's joining us from Brazil, right?
She's in Brazil, yes.
Yes, great. And Ms. Cathy Letourneau, who is here with us, who is also advisor at INROADS. INROADS being an international network for the reduction of abortion, discrimination, and stigma, which is hosted by IPAC, but I'm sure you will present more on this. So I will let you start.
Excellent.
Thank you.
Hello, everyone. It's nice to see those of you in person, and I'm happy to hear that there are folks able to join us electronically. Thanks again for everyone's flexibility and patience. We're all working together to make this happen, and Christopher Lindahl has been an amazing champion here in the room. So Bia and I are going to talk with you today about stigma, discrimination, and human rights, and making those connections for the PAC setting. And again, I coordinate INROADS. This is the International Network for the Reduction of Abortion, Discrimination, and Stigma. And there'll be some slides at the end available on the slide deck that will be shared on the website, where you can click over to our website to learn more about us. And Bia is IPAS's Senior Regional Policy Advisor for Latin America, so she's going to have some compelling examples from experiences in Brazil, as well as a good human rights context for us. So today, what we hope to cover is really understanding abortion stigma and how it manifests in different PAC settings. And we're going to explore how abortion stigma and discrimination are linked with human rights violations. We're going to present a cycle that has really been grown out of the HIV and AIDS stigma movement. And then we're going to talk about how we can apply rights-based approaches and a stigma lens to PAC. So we're not going to just cover a little bit today. So before we dive into what we mean by stigma and discrimination in the PAC context, it's really necessary to understand what we mean by these concepts, to describe how they manifest, and to analyze the relationships between them. Our understanding of stigma is really grounded in sociological theory developed in the 1960s. And the definition of stigma that you see here on the slide hasn't changed much over time or really over fields of study. We've seen this applied with HIV and AIDS. We've seen this applied with lesbian, gay, bisexual, transgender, and queer. We've seen this applied to the mental illness stigma movement, and it's really pretty consistent. And then when it's applied to abortion, we have these kind of two working definitions that are used across the field. So a shared understanding that abortion is socially or morally wrong, and then sorry, my talking points are really very tiny right now. So 1 second. A negative attribute ascribed to women who seek to terminate a pregnancy and anyone related to that abortion experience that marks them as inferior. Did that go? Thank you. Abortion stigma is as complex as abortion itself. It has many layers which tend to build upon and reinforce negative connotations. It's really a social process. It's circular. It's not hierarchical. But these things that you see on your screen on the web community and on your laptops in front of me really illustrate how it can manifest. So we have labeling difference, and this can be especially true in PAC settings regardless of the legal status of abortion. So where abortion is legal, women themselves may be labeled for getting abortions outside of the health system, whether they're accessing safer channels or whether they're accessing unsafe methods. And where abortion is illegal or criminalized, women may be labeled for seeking abortion at all. And then stereotyping, we really link this to undesirable characteristics. So in some of the research that IPAS has conducted, women have been labeled as sinful, selfish, dirty, irresponsible, heartless, murderous. And this really belies the fact that many abortions are undertaken to preserve the health and well-being of family members. Separating. People are categorized to separate us from them, to separate PAC from the broader context of sexual and reproductive health, to separate abortion providers from general OBGYN, from general women's health, to separate women who have abortions from those who do not. And this again belies the fact that abortion is a common experience in the reproductive lives of women. And finally, discrimination, which is what we're going to be diving in terms of integrating a stigma lens in a human rights context. There's an example, a recent study was published describing PAC services in Sri Lanka where women who seek abortion perceived judgment and then reported lower satisfaction of care in their services than women seeking miscarriage management or giving birth. So stigma and discrimination plays out in that PAC setting. Stigma is something that we can both experience and perpetuate. And so research is really, it's important to consider these three domains of stigma to help organize our thinking and how we can move forward to address stigma. Perceived stigma refers to an individual's perception of how other people feel about abortion and women who have them. So that case in Sri Lanka where women perceive that they might be treated differently might put a lens on their entire experience to start with. Experienced stigma is that what is actually experienced when women are treated differently because of seeking abortion or post-abortion care, when providers are actually treated differently because of the care they're providing. And internalized stigma, this is a sticky one, it really encompasses that process of taking other people's thoughts or beliefs and internalizing them. And this is where women will often manifest guilt, shame, anxiety, and might fear that disclosure, and so we can end up perpetuating the myth that women, not that many women have abortions because women do not want to talk about their abortion stigma, that abortion experience. But we can also perpetuate stigma, and all of us can be stigmatizers without even knowing it or comprehending kind of the impact of our language and frames. And we perpetuate stigma at the same time as experiencing stigma by simply upholding some of the societal expectations of what is considered normal, some of the language that we use. And so you'll see in a lot of stigma mitigation strategies, it's about reframing the language that we use. So right now we're going to see if this transition works. So I've kind of given a grounded in how we understand stigma from a conceptual perspective. And so Bia is going to talk with us about the human rights approach. And so I'm going to see if she can actually advance slides herself or if we need to advance them for her. Christopher's going to advance the slides for Bia.
Okay, thank you, Kelly. Good morning, everyone. I hope everyone can hear me from here. I'm going to share with you some of the human rights-based approach concepts and also try to think what Kelly just presented on stigma and this other human rights-based approach in order to protect women's human rights during post-abortion care. So in order to understand abortion stigma, we really need to ask what is the social meaning of abortion, criminalization. When a state criminalizes induced abortion, it is constructing its social meaning as something wrong and harmful to society. In criminalized abortion, states are stigmatizing women, undermining their capacities, questioning the way they enjoy their sexuality and how they fit or not fit their social role as mothers and caregivers in society. So the law is used as a medium through which stigma is created and reinforced. But in any case, no matter what the law says regarding abortion and how states choose to regulate abortion, states have obligations and human rights protected under international human rights treaties and conventions. So what is the human rights-based approach to post-abortion care? It aims to protect women's right to privacy, information, to be free from inhuman and degrading treatment, freedom from discrimination in health care, and other human rights. When addressing and preventing human rights, states can mitigate stigma and discrimination and improve health outcomes. Human rights approach to post-abortion care requires paying particular attention to more stigmatized, vulnerable, or marginalized groups, such as adolescents, ethnic and racial minorities, indigenous women, women with disabilities, sex workers, HIV-positive women, displaced and war-affected women, and women living in underserved areas and other stigmatized and excluded populations, especially vulnerable to ill health and discrimination. So what are the human rights related to sexual and reproductive health and post-abortion care? And what are the legal obligations from governments and health providers working in public health facilities and providing post-abortion care? For example, the right to non-discrimination, which means that women and adolescents should be treated equally with no discrimination on the basis of sex, marital status, age, race, economic status and health. Also means that health providers should respect for differences. For example, women not being denied of health services which only they need, such as post-abortion care. Also, the right to the highest attainable standard of health, which means work towards the availability, accessibility, and quality of health care facilities, and to create the underlying preconditions necessary to realize the right to health, and to ensure the adoption of laws, policies, and practices according to human rights standards in post-abortion care to women and adolescent girls who need it. The right to life, survival, and security means to ensure women's and adolescents access to healthcare services without facing risks to their health and life. The failure to address preventable causes of maternal death is a denial of women's human rights. Governments have an obligation to respect rights, for example, refrain from denying health care that only women need, to protect rights, prevent human rights violations to happen, and to fulfill rights, to take appropriate governmental measures toward the full realization of rights, for example, allocating resources for and setting in place good quality of post-abortion care services. How does this look like in the context of post-abortion care? What happens when there is no human rights-based approach in health practices during post-abortion care? The situations described now are examples of lack of human rights-based approach and good quality of post-abortion care, showing the negative impacts of stigma and abortion criminalization on women's health and human rights in public health facilities in Brazil. So I'm going to read some women's testimonies that were collected in a study developed by IPAS and partners in some states in Brazil. About unhuman care. If I had not brought a bedspread from home, I would be freezing in that uncomfortable chair. I've been here since yesterday, 24 hours thus far, 12 hours and 45 minutes without eating. I think that I'm waiting for a curettage procedure, which I believe will be performed this afternoon. But here, it informs you on anything. Next one, please. We arrived early. I remember that there were only 2 people ahead of me, but they were taking a long time to treat me. Other people started arriving and they went right in front of me. I think it's because they knew that I had induced an abortion. I think that when women induce an abortion, they punish them harshly, leaving them lying in the corner. I was with my sister and my mother. We waited in the waiting area, but they didn't take me in. They didn't even bring a bed. I remained seated. I had a very big tampon, but even so, when I got up from the chair, I saw that my clothes were drenched in blood. The receptionist called the doctors. I think that if they had not seen all that blood, I would have taken longer. I know that I got there at 7 a.m. and they took me in around 10. Now a provider's testimony. Sometimes, even with error mortgage, there was a case of a woman who smelled awful when she was finally able to be seen. She spent more than a day waiting in triage. With missed abortion, with sepsis, even so, she was the last one to be seen that day. That's how it is. When it's an abortion, they don't even want to know whether it was spontaneous or induced. The woman is left for last in admissions. These situations reveal different ways to punish and discriminate against women who have abortions, such as delayed treatment of care, no adequate space for abortion care, contributing towards exposing these women to lack of privacy, judgment, and unhuman care. They feel cold, hunger, pain, bleeding, long waits, lack of information, lack of privacy, discomfort, and attitudes of recrimination, blame, and punishment. enforcing and perpetuating stigma. Also, these situations illustrate several human rights violations, such as the right to the highest attainable standard of health, the right to life, survival, and security, the right to be free from inhuman and degrading treatment, among others. So now that we've touched on the application of human rights-based approach to post-abortion care and illustrated that with a few cases how women experience several human rights violations during post-abortion care, I'm going to turn it back to Kelly to link this back to abortion stigma and give us a plan for moving forward. Thank you.
Thanks, Bia. I'm really glad we were able to have that connection work out. So I want to kind of bring this all together with this model. Again, this was adapted by some work that's been done in the HIV and AIDS world, and really emphasize that stigma and discrimination are interrelated. They reinforce and legitimize one another. Stigma is really at the root of discrimination, and sometimes we can even call discrimination enacted stigma. And this is what leads people to act or not act in ways that harm or deny services or rights to others. And so really focusing on stigma in the PAC setting, it's more than about patient satisfaction, it's more than about patient compliance, it's more than about compliance with procedures on the provider level, but really about these intrinsic links between stigma, which manifests as discrimination, which creates the conditions for human rights violations. These violations in turn legitimize and cement stigma, reinforcing the labeling and stereotyping of women, reinforcing the silencing and shaming of women, reinforcing the separation of providers from their overall medical community and from the public health community. So let's be clear, discrimination is a violation of human rights, and considering a human rights framework might pave the way for how to intervene to address stigma and discrimination. And this is a cycle, so applying a stigma lens and continuing to develop what we know about abortion stigma can pave the way for ensuring that services are accessible and rights-based. And thinking back to what Kat and Maureen were saying earlier, for ensuring that that transition from a separate focused PAC care into PAC being part of an overall comprehensive strategy for abortion, comprehensive abortion care being part of an overall comprehensive strategy for women's sexual and reproductive health. Working this cycle together can help move us in that direction. So I want to consider an applied example, and Kat mentioned earlier about the Helms Amendment, which was passed in 1973 by the representative from my home state of North Carolina, and it prohibits the use of funding for the performance of abortion as a method of family planning or to motivate or coerce any person to practice abortion. And in the context where abortion is stigmatized as it is, it's really easy to overinterpret these words. It's really easy to have this lead to what in effect has been a total ban on U.S. funding for abortion care even where it is legal. It leads to a denial of funding for any abortions, even when a woman's life is threatened, when pregnancy is a result of rape or incest, to preserve a woman's health, or in the cases of fetal anomalies. And I don't want to privilege those kinds of examples over the context of the more common abortion experience, but these are clearly not methods of family planning when these are the examples. And that's what Helms prohibits in its language. But because abortion is so stigmatized, it creates the conditions where we perceive stigma in terms of the fear that if we narrowly interpret Helms in an organizational or a funding strategy, that there are going to be adverse consequences. In terms of the mainstream human rights community, they have not prioritized action on this front because of stigma. Voices criticizing the application of Helms are frequently marginalized. It's hard to get through to the top level of policymakers with critiques. And organizations, frankly, are fearful, and that leads to a separation of services, like Kat described earlier. And all of this leads to the violation of human rights, where it denies healthcare providers the means to ensure the highest attainable standard of health for the women they serve, and women are not given the information and education that they have the right to. It's depressing. So I want to stop to consider the pathways that women must navigate that bring them to your PAC service. And so by the very nature of post-abortion care, we know that abortion is somehow unavailable. Either it's criminalized to the degree that we saw in the examples of Brazil, or access is limited to the degree that women are seeking abortion outside of the health system. In a stigmatized setting, you can see this wall where the woman's isolated from her community. She doesn't know who to ask. She doesn't have access to information. All that we know is that abortion is unavailable. Now, I do want to acknowledge there is a changing landscape of abortion methods and availability, and a lot of the organizations in this room have been working hard to buttress that, and we really are seeing more success where women have access to safe misoprostol. And stigma creates the conditions where information about such medicines might not be readily available, overshadowed by myths, and women might be marginalized in other ways, such as the rural and poor women, young women that Kat mentioned. And so now she needs post-abortion care, and we've seen in the earlier case examples that she might be treated poorly, and this manifests as stigmatizing attitudes and behaviors where providers might actually stigmatize those women. So what can we do? And I've been told I have 1 minute, so I'm going to really try to quickly share with you some approaches. So one is doing this in a two-phased way simultaneously, applying a rights-based approach and applying a stigma lens. And so applying a rights-based approach within the PAC context to reduce and mitigate the impact of abortion stigma by ensuring that rights are respected, protected, and fulfilled. And simultaneously, it's important to move forward our understanding of abortion stigma and how it manifests. Stigma is what consistently thwarts us as we advocate for law reform, as we work to improve access to information in communities, and as we train our cadres of providers and try to improve quality of care. So it's really important to address stigma. I'm actually going to just kind of move past the slide simply because I think Bia really gave us a great foundation for what it means to apply a rights-based approach. And simply I just want to emphasize this model of participation as a principle and practice when thinking about a rights-based approach, and to consider that in a human rights framework, women are active agents who are entitled to participate in decisions that affect their sexual and reproductive health. That's just kind of one of the take-home points, but I do encourage people, these slides will be available after the presentation. And so what this means for PAC is that post-abortion care is a right, as is abortion, and what that means is important. A rights-based approach means that comprehensive, women-centered services and care are provided to all women regardless of what health center staff think about abortion itself or about women who have abortions, and women are not excluded from care based on any personal characteristics or traits. And so we have a slide at the very end with tools for how to apply a rights-based approach and how to provide women-centered care that are linked on the slide deck. So if we come back to this formula, let's talk about applying a stigma lens. So this is a big slide that kind of presents our entire learning agenda for moving the field of abortion stigma forward. I'm not going to walk through all of it, but I do encourage folks to take a look at the published article on this learning agenda for abortion stigma. It's available in an open access journal. The Journal of Women in Health has a special issue on abortion stigma, and all of the articles in that issue are free for download until March. So that link is provided at the end. But we do really understand that stigma operates at all of the levels you see here, the individual, the community, the institutional, which is what we frequently call the health systems, the legal and policy, and then the overall framing discourse of mass media and culture. And so this learning agenda paves the way for asking the questions in your system, in your country, in your community. How does stigma manifest here, which brings to light where you need to intervene. And so as mentioned earlier, abortion stigma underpins the very reasons we have to be here to look at PAC as a separate entity, and it thwarts us when we want to integrate into that comprehensive system. So moving this learning agenda forward will really help implement a human rights-based approach to move forward. And so in honor of September 28th, Global Day of Action, the PAC Consortium Community and Stigma Task Force put together a statement about what stigma-free PAC would mean, envisioning it from where we are now. And I want to be clear, without abortion stigma and all of its manifestations, PAC would look more like the comprehensive service that Kat outlined earlier. But it's really important to think, where can we go with where we are right now? And so for the foreseeable future, PAC is one of the many tools we have at stitching together a safety net of care for women. And you can see here that the task force envisions that women and girls in stigma-free PAC services have knowledge, have respect, have access, justice, and health. And so we're going to briefly reconsider the pathway that women may navigate to bring them to your PAC services. In this reimagination, stigma is reduced. Women have increased skills, information, and capacity to mitigate stigma that exists. And at all points, healthcare providers are grounded in a rights-based approach. In this pathway, women can talk to the people in her community. She has access to the information to get a prescription for misoprostol, and she knows the appropriate dose to take and when to take it. But perhaps she does experience a complication, or she's not comfortable with the amount of bleeding, and so she goes into your health system, and there she receives services that adhere to the highest standards of care. When there are decisions, such as wait and see versus MVA, does she want contraception, if so what kind, she's given all of the information and is a participant in that decision making. She successfully completes her abortion, acquires whatever other health services or psychosocial support she needs, tells her community about her experience. A few weeks later, another woman hears about her experience and feels more confident going to this health system for care. So stigma and discrimination are interrelated and really create the conditions for violations of human rights. So applying a rights-based approach and taking steps to understand how stigma manifests at multiple levels can help us move forward. Here are your tools and resources. I'm not going to walk through them since everybody can click on them. The slides that are available will have embedded links. And also consider joining En-ROADS, the International Network for the Reduction of Abortion, Discrimination, and Stigma. That's it.
So thank you very much, Kathy and Bia, for this excellent presentation. Now we're going to open the floor for questions and answers. Yes, please.
Hi, my name is Kate Cho. I'm from PAC Associates. I had a question regarding, I guess maybe it's related to the learning agenda, is whether or not the field of looking at stigma and abortion care, if you had looked at how stigma is treated in other health fields and related areas, for example, I don't know, like how obesity is treated in healthcare settings, maybe how mental health used to be treated historically, or how refugee populations are treated. So I'm just wondering if maybe we had broadened the lens a little bit to see if those concerns could be applied to this setting.
Absolutely. That learning agenda that we presented was conceptualized when a global meeting of scholars and practitioners in abortion care, but also in stigma in general. So HIV stigma and mental illness stigma representatives were there to conceptualize that agenda. And we've also been looking at some of the evidence around what's worked in terms of reducing HIV stigma and reducing stigma around mental illness, which is still quite a problem. And we have some ideas about different approaches. And so in the United States, for example, you're seeing a big focus on individual storytelling. But in other areas, you're starting to see a focus on reframing language within the health system context. And that's where the values clarification activities can be really powerful. Where we are, we're so early in the field that we've recently developed measures of stigma across these different levels. So IPASS has a scale. C-Change program has an individual level scale. There's some researchers out of the University of Michigan who have scales for measuring provider stigma that are now being adapted outside of the United States. And so we're at that place where it's important to start measuring it and then seeing if any of these strategies actually reduce stigma and how that's linked to health outcomes. But we don't have a big body of evidence for that yet. So it's an exciting time. And En-ROADS does have a small grants RFP for local community-based organizations that's open right now for trying to answer some of these learning agenda questions, both from the research area or from trying an intervention. So I'm happy to follow up about that if anybody's interested.
I think this is Catherine. I'll jump in too about the values clarification work, which also drew from values clarification work and tools that had been developed in the HIV field. as well as other fields such as lesbian, gay, bisexual, transgender rights, as Katie was linking in the stigma work as well. And so we kind of drew from, adapted, and created new materials around values clarification for abortion. But I think that we see some commonalities when we're talking about sexuality-related stigmas or stigmas related to behaviors that are considered socially undesirable or unacceptable, which goes back to kind of the definitions of stigma in the first place. And so those values clarification interventions, the framework for values clarification interventions, and the evaluations that we've done have shown globally that we're seeing a change, a positive change in knowledge, attitudes, and behavioral intentions related to abortion. And so we really can see some, again, some positive results of the values clarification work in terms of people having enhanced attitudes towards abortion. Yeah.
Thank you. Marie?
Okay, thank you. This is Maria Rodriguez from BSI. Just to add to the presentation and the point that Kent made, we were able to adapt the values clarification exercise for post-abortion care programs. Of course, post-abortion care and comprehensive abortion care, they're, continuum. We all, agree on that, but sometimes you specifically need to focus on PAC. And it's quite easy. You just, take the list of statements and you adapt it to the country, and even within the legal framework, we have done it in Rwanda, we've done it in Zimbabwe, and it worked well. So, because when you put it out as this is about abortion, if you're specifically working on post-abortion care, sometimes people may be slightly averse to that idea, but it's very easy to actually just make it post-abortion care.
Maybe while we're adding about adaptations, I mentioned the adapted values clarification activities for abortion care for young women. We also have them on second trimester abortion, and these are all available on IPAS's website. Additionally, I adapted some of the values clarification activities to look at method, actually misoprostol for post-abortion care, misoprostol for abortion care, because we're seeing that among providers there often are different attitudes or biases towards one method or another, which obviously influences the kind of methods that are then offered to women. And that, kind of transferring the burden of the experience of abortion from the provider to the woman, and what that means in terms of providers' willingness to provide abortion, but also women's experience of abortion or PAC is different depending on the method that's used, whether it's mifepristone, misoprostol, or misoprostol only, or MVA or vacuum aspiration. So actually some values clarification around method choice or method of uterine evacuation is important as well.
I just want to add one comment, just reflecting on the sort of stigma issues with primarily with health workers themselves, and just would love to see some ways of working with faculty, so that during sort of the basic education that actually health workers are really sort of working with faculty and working with clinical preceptors, so that health workers, younger health workers coming into the health system are really experiencing reduced sort of stigma, or sort of the awareness around, and I think that's where it would be really wonderful to see some values clarification built more into nursing school curricula and sort of continuing professional development activities. I just think, anyway, that's something I would really love to see, because I think when we really think longer term, there's work with current existing health system practitioners, but then there's the whole next generation, and sort of what can we do to sort of bring into the health system health workers that understand their role. So thank you to both of you.
I'm making a note about En-ROAD's audiences in terms of thinking about how to reach those, because as you saw with that learning agenda, it really takes a socio-ecological approach to all of the levels where stigma works, and that's exactly a fine point that we need to be thinking about the different, not necessarily usual partners that we work with.
Do you have more questions? Chris, do we have any questions from the online attendees?
Yeah, we do have one question coming in from Pakistan. It's about social stigma manifesting as religious stigma. We can face social stigma at some level, but how do we face religious stigma? Because people are emotionally and spiritually engaged with religious laws.
And that's something that we've seen in terms of some of the measures of stigma that have been applied, where if you're measuring stigma, if you're in a place where religion plays a very big part of how stigma around sexuality, where stigma around abortion operates, it's important to have those measurements. But what Kat mentioned earlier was really working with a broader array of diverse partners, such as faith leaders. And we've seen that in some countries, people have been able to successfully build bridges with faith leaders who, on the face of it, seem like they might be opposed to what we're doing, but once you dive deep, they're really supportive and are happy to work towards health access. And so that's an important partnership to make, but it's also starting with measuring. Is religiosity a really big part of how stigma manifests in that community? Because we do know stigma manifests differently depending on the local context.
And recently, IPAS held a webinar on faith-based kind of approach to abortion care, and I think it's important to recognize that a lot of healthcare providers and others working in abortion service delivery are people of faith, and in fact it's their faith that drives them to offer induced abortion or post-abortion care, and that we can't always necessarily let kind of extreme religious people in the opposition frame the abortion care dialogue around religion to necessarily mean that religion prohibits abortion, that there's a real moral stance on abortion service provision, and that increasingly we've been engaging more religious and faith leaders around this and engaging them around the problem of unsafe abortion and kind of the religious imperative to intervene and do something about this in their setting. And that through the values clarification process, I know many of our participants have talked to their faith leaders as part of their own personal journey in their values clarification process around abortion and come to their own understanding about how their faith and their faith community, in fact, can support them as providers of abortion care or post-abortion care, given the toll that unsafe abortion is having on maternal mortality and morbidity, and again, that the religious community has a proactive role to take in addressing and eliminating unsafe abortion.
Thank you very much. So please join me for a second round of applause for Kathy, Maureen. So we're going to take a quick break, maybe a shorter one because we're a bit late. And, maybe 10 instead of 15, and then we'll resume with the country experiences from our colleagues from the field. Thank you very much.
So welcome back to the second session, and maybe I just had one point to share. This was about the religious community and how they influence stigma. For HIV/AIDS, we had a practical experience where the use of role models or models to address stigma was one of the key strategies. And one of those role models was actually a pastor. And he did a very good job in terms of, bringing his flock to accept. Those were in the very early days when HIV was still highly stigmatized. He was also a very good speaker, was trained a bit on some of those skills, and managed to, do a great job in addressing stigma. So I think it's possible, and there are inroads, even with very extremists, or, for lack of a better word, you can still have the moderate ones, joining you and using those to address stigma. Now let me move to this session. This is the second one where we will be hearing from country experiences and how they have addressed stigma particularly. There is also the other dimension of quality of care for PAC. We hope that we may discuss both of those dimensions. The first speaker is not with us in the room, but she's actually with us virtually. This is Dr. Indira Basnet. Indira Basnet is the IPAS country director in Nepal, and she's online with us. She has about 25 years of experience in conducting that. We will invite her now. Indira, you have the
Thank you. Can you hear me?
Yes, we can. Please go ahead.
Yeah, okay. Thank you. Along with my Nepal team, I feel myself fortunate to share Nepal's story on the relevance of continued PAC in Nepal even after legalization of abortion in 2002. Let me start with the story of Shanti, who was arrested and thrown into prison after the authorities accused her of having an abortion. It happened 20 years before, when abortion was considered as a crime punishable in this Hindu kingdom with a life prison sentence. One fateful afternoon, feeling sick and dizzy, she swallowed some paracetamol tablets to cure a nagging migraine. I knew instinctively that I was miscarrying and I had lost my baby, she recalls. My underclothes were drenched in blood. Shanti turned to landlady of her rented house in Kathmandu for help. The woman took her to hospital but reported the death of the baby to the police, something that she was legally obliged to do as the owner of the property. Because Shanti's pregnancy was far advanced, the authorities suspected she had induced an abortion. She was arrested while recovering in hospital, and 4 armed police stood guard by her bed. I was so sick, there was no reason for them to guard me. I could not run anywhere, she said. Her husband took care of the 2 teenage daughters. But Santi requested that her 5-year-old son stay with her so that her husband did not have to give up work as a taxi driver. After hospital, she was transferred to a jail and her son went with her. Santi was sentenced to 20 years in jail and was released in 2002 when Nepal legalized abortion in September 2002 after pressure from human rights organizations. For many years, women in Nepal were subject to one of the strictest abortion laws in the world and had highest maternal deaths in Asia. Before 2002, abortion counted for 15 to 30% of maternal mortality. More than half of gynae and obstetric admissions were for complications of abortion. Women were put in the jail for several years. It was strictly illegal and culturally not acceptable, and many women were seeking unsafe abortion in unsafe environment. Abortion was legalized in 2002 and first service was introduced at hospital. I would like to share here that the background of post-abortion care and when it started. So prior to 1995, any incomplete abortion was treated with sharp curettas in operating theater. In 1995, MBA for PAC was introduced in one of the largest maternity hospitals, but could only be performed by physicians. However, by 2004, with intensive advocacy by the Safe Motherhood Program, PAC was fully integrated in MOC as a life-saving care, and mid-level providers were trained in MBA to ensure 24-hour availability of PAC services. We did several evaluation performance of the mid-level trained providers as well as of the physicians who were trained in PAC. In Nepal, we adopted the standard as per WHO, so that included comprehensive post-abortion care. And the evaluation findings highlighted that nurses were competent providers of PAC and generally provide more comprehensive care. That means providing pre and post-abortion counseling, offering post-abortion contraceptives, and using appropriate technology than physician providers. And this slide, I would like to highlight that what was the effect of legalization in Nepal in 2002. You can see in this slide that legalization led to reduction in the most serious maternal death complications due to unsafe abortion. The steepest decline was observed in 2007 when second trimester abortion services were introduced. At the same time, there was increased service provision of first trimester abortion and PAC by the mid-level providers. So this slide shows that the effect of abortion legalization, pre-legalization and post-legalization. So obviously you can see that how really it affected on improving women's health, those who were suffering from severe abortion complications. And in the next slide, I wanted to highlight that in Nepal, when abortion complications, management of abortion complications or PAC was fully integrated with EOC monitoring system, then we found that in the beginning the change was like not significantly, slowly coming down. And by 2008, the complications due to unsafe abortion was declined nearly by half, from 41% to 26%. And this is the findings from 19 districts, and then we also collected data to 22 districts. So this is the total data from 22 districts, and that continued from 1998 to 2008. So I just wanted to here highlight one important information, that these are the severe abortion complications which our HMIS system has defined. What are the severe adverse events? We did not include here mild or moderate incomplete abortion, but only those who really needed life-saving care as per WHO definition. So these are the severe complications. And in next slide, you'll see that there is generally increasing trend in mild cases of PAC. So here you can see that the data from 2008 to 2012. In 2008, in Nepal, we introduced medical abortion by mid-level providers as it was approved by the Health Ministry. And what really happened, very interesting factor here, because all of us, we know that, some women, they are under the process of abortion, even after medical abortion. Like some women, they may go like even more than 3 to 4 weeks. So if some complications like minor complications, bleeding, lower abdominal pain or something complain, then women will go to the health facility, because PAC was treated as free of care. Women did not have to pay. Rather, instead, it was included into maternity incentive scheme. So women, they will get also, they will be reimbursed for their transport cost and then the treatment cost. So that's why suddenly the HMIS found increased number of PAC. So later we analyzed and we found that these are all like, mild cases. And we assume that because of the availability and use of medical abortion by women, which can be purchased outside of a health facility, this may also be why the presenting PAC cases tend to be mild cases of incomplete abortion without serious complications. So these are, as compared to my previous 2 slides, this is only simply very mild cases of incomplete abortion, but still it is recorded in HMIS. And the other slide that I wanted to show here was really monitored by IPAS intervention sites, where we found that total during 1 year, this data is for 2012 to 2013. This is from 9 intervention hospitals, IPAS supported hospitals. We found there were women admitted with severe adverse event 53 in 1 year, and out of 53, 43 were serious, and 53 cases have also received initial abortion service outside of the health facility. And we found that nearly 50%, less than 50%, they had medical abortion from the medical shop, and little more than half, they had unsafe abortion, like as per definition from WHO, we counted them as unsafe abortion. So this shows that even after the legalization of abortion also, women, they were choosing unsafe abortion, or they were choosing to take directly medical pill, medical abortion pills from the shop. So why this? And this is very interesting in the case of Nepal, where abortion is legalized. Who are these women? Why they are going directly to the medical shop? Why they are choosing unsafe abortion site even when the fact is abortion is legalized? And in my next slide, I would like to highlight that in Nepal, when we introduce post-abortion care, even during that time also, woman, she was not required to provide a reason for incomplete abortion. She would come to the health facility and then she will demand for treatment. She did not have to say the reason. However, this was the case only for the urban, literate, and very, like rich women. But for the case of like rural, illiterate women, they will continue to be harassed occasionally by providers with such questions that why you chose to taking abortion in the unsafe. And especially in the community, women with unwanted pregnancy prefer to seek abortion in another village, obviously due to prevent stigma. and more like very under like at high risk were those marginalized married women belonging to like minority like religious like Muslim, illiterate and rural. They were afraid to make decision for their body, and often they seek their husband's consent for abortion. And as always, for post-abortion contraceptives also, they had to take consent from their husband. So what we are experiencing now, who are the most having stigma? So in my next slide, you will see that mostly this is from the data that we collected from 2 districts where IPAS had interventions. So mostly now we are feeling that abortion is legalized, this is fine, but still there is a lot of stigma around abortion with young unmarried women, and this starts in the home and continues in the community and in the health facility. For example, in Magdit district, one of the very remotest hilly districts, a young girl was raped by many young men in the community. Due to shame and fear, she did not tell her family or seek care. Instead, she committed suicide. And just to inform you that suicide is on the rise among young women of reproductive age. Like in 1996, we had 10% suicide among the reproductive age. It went to 16% in 2006, the DHS survey showed. So and the main, we did verbal autopsy also in the community late after, in 2008. And the findings of verbal autopsy showed that unwanted pregnancy was one of the contributing factors for suicide among the young women during this period. And my other slide, I want to highlight that women are continuing purchasing and using medical abortion from the medical shop or elsewhere. Then they require post-abortion care treatment at a health facility. But those women, when they come with post-abortion, some like minor complications, the providers, they perceive them as like ignorant or foolish. If a woman seeks medical abortion from a medical shop, instead of going to a health facility, it may also be assumed that she has done something wrong. She is labeled as that she is doing something wrong because she is ignorant, she is not updated with the legal condition of abortion in the country. And providers, they are not really trying to understand their concerns about privacy or confidentiality. Providers blame women presenting for PAC. There is a lack of understanding as to why women, including young women and unmarried, would seek abortion services outside of the government-approved health facility. So in a way, we are facing with women are facing with double stigma. They are stigmatized to have, like a young and unmarried, to get abortion in the health facility. But when they go to, come with some minor complications from medical shop, then they are blamed like, why did you go to medical shop? Why did not you come to health facility? That means you don't know our abortion law. And, despite of all these challenges and experiencing stigma, we do have some successful strategy to reduce or to prevent stigma. For example, providers are not required to report an indication to provide post-abortion care at any gestational age or induced abortion up to 12 weeks of LMP. Follow-up care is not mandatory. Women seeking PAC or induced abortion service do not have to register their name to respect their privacy. IPAS sites receive whole site orientation during which all staff engage in value clarification around abortion-related care, especially for the second trimester abortion. Women do not have to file a police report in order to receive services in cases of rape or incest. So these are the strategies we are implementing successfully in the government-approved health facility for comprehensive abortion care. And my next slide will highlight a few successful examples of how we are addressing all barriers or making our health facility youth-friendly, so that young women, they really get, safe access in the health facility for safe abortion. So this is again the data findings come from our IPAS interventions to districts, and we found that out of total women obtaining safe abortion services from government sites, quarter of women are young, aged below 24 years. For privacy and confidentiality, provider offer medical abortion out of the formal health facility setting, where young women feel more comfortable. It could be under tree, it could be in the tea shop. Wherever young women, they request provider to provide them medical abortion care or information. So this is really very, we feel proud of our providers. They are really becoming youth friendly. Providers are also becoming sensitive to the cost issue and provide free services if necessary, especially to the young women. On the issue of third party, young women below 16 years can bring anyone condition. Anyone below 16 years can bring friends, family members, neighbors for written consent. It does not have to be like necessarily like parents only. Our experiences in working with two young women in two districts revealed that peer leaders can destigmatize abortion-related care and contraceptive methods in the community. And in the, I also wanted to highlight here that, recently I visited 4 or 5 districts in IPAS intervention sites, and I found that in most of the cases, who are really stigmatized and who are the first person, I found that in most like women, rural women, they are saying husband or mother-in-law, because they have to first get approval from their husband or mother-in-law. So for example, when husbands are away out of the country, mother-in-laws are stigmatizing their daughters if they are found to be using contraceptive method, because they don't need basically contraceptive methods. So stigma is not only around abortion in Nepal, but stigma is also around contraceptive methods also, because it has been perceived that you need contraceptive only when you have your husband with you. When your husband is away, you don't need contraceptive method. Wives are leaving the country to work out of the country. If they are leaving, their husband do not approve of their using any contraceptive method. So stigma is around contraceptive methods also. So, what really we propose to reduce stigma as our future work? We want to integrate value clarification with provider and peer leader training package, and implementation of an educational program such as peer education, community-based SRS discussion and education, focusing on contraceptive use and targeting husbands and mother-in-law. And finally, to conclude my story from Nepal, I would like to conclude that our story from Nepal tells an important story about why liberalizing the law is crucial. But due to stigma and other barriers, additional interventions are equally needed to ensure all women's access to safe and legal abortion. Thank you.
Maybe I can allow 1 or 2 clarification questions. I see none. So Indira, just hold on. We will be having a session after 2 other country experiences. Now, the next speaker is Dr. Patricio. Dr. Patricio Sanhuesa. Sanhuesa. A reproductive health coordinator from Mexico City. Dr. Patricio is the head of reproductive health of Mexico in the Ministry of Health, and is also the chair of the Mexico City Committee for Prevention of Maternal and Perinatal Mortality. Obstetrician and gynecologist by profession, and has a wide experience in the field of obstetrics and gynecology. He has also a lot of experience in research. I won't go into a lot of details about him, but Dr. Patricio is not very complete.
Thank you very much. Good morning, and thank you for the invitation for our partner from Genuity. I see too many friends from IPAS and different NGO who have been working with us with the Mexico City government. I would like to explain a little bit what it's about, because they say Mexico. I'm speaking on behalf of the Minister of Health of the Mexico City, which is the capital. It's very complicated with services, the public service in Mexico, because we have around 6 different systems, but we have a group of 32 hospitals, 250 primary care centers, and 35,000 workers. So with this small, and we work in 16 districts in the city, 16 different countries. We give service to 5 million people. The city has 10 million people and is surrounded by Mexico State, which is another 15. So we have spoken about 23 to 25 million people. Well, since the law was approved in 2007, now we have more question than answer. I will be the instigator today to the program. So we started from one day to another, overnight, like they said, but we work in advance with different NGO to do the guidelines and try to offer services in hospital at the beginning, and then we moved to primary care centers. But what happened, and that's the first answer, because we thought at the beginning that was in Mexico City and then from all the country. But that never happened. I'm afraid after the legalization in the Mexico City, some states increased the effort to further limit a legal indication. So within the 32 states, abortion remained restricted with primary only PAC services available. Rape is the only legal indication in all states, and about 1/3 allowed for health risk, fetal malformation, and other causes. What the implication of the national dichotomy on abortion and PAC services is in Mexico City, the public sector, just we, the Minister of Health, we offer the legal service, and we don't know why. Because there are others, I mean the same law for the same city, but just we are the same people since we started, just a very small group of providers for around 400 OBGYN, just 20 accept to participate in the program. We didn't fight with the conscious objection at the beginning, but liberty of conscience, which is it work. And the result are, since then, we have been offering service to 132,000 women with no complication, no medical complication. The other big question is, where are those huge amount of number of women asking for services? Because we I remember doing with Rafaela, all the numbers, how many women we have to offer service, and they spoke about 300,000 in the country, 360,000, and then 200,000. But our number the highest number was 2,000 per month, so it was around 24 per year. And we know we have a very good mouse-to-mouse report for different providers, big providers, private providers, and all of us, we offer about 50,000 procedures per year in Mexico. That was the last information. So what happened, we don't know. We don't know. We have an idea. Maybe more self-induced medication. So maybe we are migrating from providers to women's hands. Maybe they don't need us because you can buy, Mife and Miso on the pharmacy. We did one research with the effectivity of misoprostol alone, and we discovered that 1 every 4 women accept that even if we offer service for free, and in 3 hours everything is done, medical abortion or MBA. We don't offer DNC, an implant or Mirena, everything for free, but they don't like to come to us. So you say, so what happened? We are free, we are quick, we offer counseling, compassionate counseling, we do everything, but they don't come. Maybe they don't want to answer to many questions that we did before. One of the barriers and one of the stigma that in order to do the thing very accurate and precise at the beginning of the program, we have this wonderful idea to ask the women why they were there. So we have a list of 17 different questions about what are you coming here for an abortion? Because you are too young, or because you are too old, or because you don't want to study, you want to finish your study, because you are running out of money. So in the question number 9, the women say to the social worker, because I wanted, because I needed. And it was weird, so finally, and that was one of the advice for another NGO who maybe to do a research, And they say, we have to get out of this question because we are putting barrier and we are very, and they don't like that. So that was a big question. You have to take care when you put the right question in the medical record when you offer this type of services. What happened in the state? Legal indication do not equal access, system not in place. 27% of the abortion reported by the minister belong from women from other states, 24 from Mexico state, and 3 from all other states. Medical abortion medicine is available, but safe abortion services are not. Unconscious objection law presented in 6 states practiced widely. PACs in Mexico, before and after the legalization, okay. But this is in the whole city, not just in our system. At the beginning, prior to aborto legalization in 2007, highest level of care of women, hospitalized and treated with surgical. After legalization in the, yes?
Can I just, what is the conscientious objection law, just as a point of clarification?
Excuse me?
A conscientious objection law, you mentioned it in the preceding slide.
Mm-hmm.
Let's allow him to finish.
Okay, I'll hold that. I just
hold
okay.
Okay.
Okay, but do you mean, let me think, because I cannot, do you think what is the law in our system?
Yeah.
We never did anything, so you don't have to sign anything. If you agree to participate in the program, it's okay. But nobody had been signing anything against or in favor to the program. That's what we did. Of course, it's a law that just a provider or OBGYN or general practitioner who are training can say yes or no, but we don't have any paper signed since 7 years. I hope to answer your question with this. So we have a prior and after the legalization, and after is in the whole city. It's not too many changes between the DNC, but in our system, we don't do DNC anymore, just MBA or electrical aspiration and medical abortion. A standard of care of the national guidelines, the DNC is a primary treatment. Is some MBA integration, a standalone clinical service, but not fully integrated in PAC, in no formal national PAC program, no comprehensive guidelines. After, misoprostol introduced an MBA integration, no change in the model, but some program offer PAC contraception, no single national PAC program or guideline. The key challenge is, the long wait, the septic abortion, and the stigma appearing, and after the reduced reliance on surgical service and more use MISO for outpatient treatment in Mexico City and 6 states. Fewer septic abortion and stigma reduced but remains. Outside Mexico City, women increasingly prosecuted for suspect-induced abortion and provider skepticism around abortion-related services and access and availability variable depend on the cost, geography, linguistic and cultural barriers. Vulnerable women least likely to access services, impact services low priority over the procedure requiring operating theaters. Medical abortion method impact may increase access and reduce stigma, improve the quality, safety, and efficiency of care, reduce cost, and increase access to the service. But it's one thought very important that I think the medical abortion, it can be the monopoly of doctors, nurses, and social workers, in my opinion. And we have this example very clear of the woman in our services. Even if we believe that we offer the best services and we are public and the state must have the responsibility of taking care of the health of the women in this type of cases. They prefer sometimes the self-induced medical abortion. So we have to think about that, because when we think about PAC, why don't we think in pre-abortion care, not post-abortion care? Maybe we have to offer all the information to the women so that when they need this, they will know where to go, where they have to call if they have some answer or they wanted to have support in case of alarm sign. And in most of the emergency, most of the cases that go to emergency, it's because it's misinformation. They get afraid. They are afraid about the bleeding, but it's part of the process. So I think we have to work on that to reduce stigma and increase access, especially that mifepristone, you can buy it in Mexico all over the country. And it's weird. It's just allowed, the law allowed to have a legal service in Mexico City, but you can buy mife and miso all over the country, even close to the border. It's two different products registered in the country and around 5 misoprostol products. With the misoprostol, we know that we have to take care because the misoprostol is very labil. It's very sensitive for changes of the weather and how need you open the case. Not the mife, but the miso, yes. So it good quality, and somebody have to put attention on what type of business or the pharmaceutical company and what type of drug they offering to the women. since we started in April 2007 to now, this is the media, 72% of the procedure were with medical abortion. We offer medical abortion till 10 weeks, okay, from 10 to 12 MBA or electrical aspiration. Those are the numbers, 72% with medication and 56 in primary care center. Now we shift from hospital to primary care center. Now the new thing, the good thing that we are very enthusiastic is that we offer implant. We do the quick start study. In the same time they take the MIFE. Doctor, they are not the only one who can offer the MIFE to the women. We understand that between women sometimes it's easier. Nurses. And in some occasion women doesn't want to take the MIFE in front of the authority of the health provider. They wanted to use it at home because they can use the medicine during the weekend because they work. So we give them the pill too. We are very open-minded with that. But the good thing and that we are very enthusiastic is about the LARC, because we think that maybe we can change some lifestyle, some history of the life of the women using the implant. Maybe they finish high school. So maybe that's the dream. But we have been using now about 30,000 implants in the women in the public sector, and those are for free too. So my misoprostol per PAC service, we use it for incomplete abortion too. We are documented, more than 4,000 women. It's very easy to do it. The effectivity is around 95%. In some of the states, Genuity has been working in Chiapas, Guerrero, Puebla, Querétaro, in training in 6 states from how to provide medical abortion to women in order to don't put them into the hospital. 350 provider administration training, more than 1,000 women receive misoprostol treatment, and thousands of educational material for provider and women distributed. Tax shifting to lower level of care to reducing congestion at high level. The challenge is MBAs is a safer surgical alternative to DNC, but not widely used. So most of the public system, they need training on site. This is very good. You have to do training, but on site with the expert. Mifepristone is expensive and unknown to most providers, especially outside of the Mexico City. Till you share the information with the most conservative doctor that when they have fetal death, with fetal is second try, they like to know how the MIFE works. So it's a very good opportunity to socialize the knowledge with them. Misoprostol is stigmatized, even association with the abortion, but everybody uses it. Neither drug yet on National Essential Medicine list for OBGYN indication, but I think that will be changed. Increased access to all available alternative to DNC and shift services lower in the health system. But the most important thing I think in this slide is increase women access to information, but to information of everything, not just about legal abortion and standard of care or contraception, and maybe sometimes we, the provider, wanted to not to force, but to emphasize so much in the contraception in this moment, and sometimes maybe they don't want to speak about it, some of them. Conclusion, legalization of abortion in Mexico City has been made an abortion safer for many women and will ultimately reduce the need of PAC, need to expand network of abortion provider, ongoing challenging to variability in abortion restriction and limited service through Mexico, many parallel with USA as an area, and the use of medical method as a key strategy for improving legal services, restructure, streamline abortion and PAC services, reduce stigma. That's it. So I think we need to increase the information from women, emphasizing counseling, alarm sign, and work with call center together. Thank you.
very much, Patricio. Just to ask if we have any clarification questions. One or two. Yes, madam.
So Jill Gay, What Works Association. When it was first legalized in 2007, when we were in Mexico with you in 2008, we heard that there was sort of an underground railroad, this will speak more to the Americans in the room, of women who would be channeled to Mexico City for safe abortion from Chiapas, Oaxaca, Guerrero, some of the poorer states. Are you now saying that that's a less useful model because you can distribute misoprostol, hostane at the community level and educate women, but then how do they get, if there's problems, how do they then get to the safe services?
Well, this is a very complicated story. That's, as a matter of fact, the number of women came from another state had been increasing. At the beginning, it was 3%. Now it's almost 30%. No.
Wow.
From the whole women asked for services. Most of them came from Mexico City state, which is very close by. But the other one, those are the long story. The women who came from 800 kilometers, they show up in a city that they never been. What happened depends too on the gestational age. If they are, higher than 9 or 10 weeks, maybe they are afraid to use the MISO, or they don't know. Some people in Mexico, even in Mexico City, they don't know that about the law that was legal since 2007. So I think it's a lot of need for information. And irresponsibility, on the other hand, for the government to tell to the poor people, because poor people, this is another interesting thing to share the last comment. What happened in our system, the women who go for a delivery or a cesarean section, the education is lower than they go from an abortion. The people from university, high school, so the reason is because that, because they know about the law, they read more, they have more information, they know their rights. Maybe the other ones, they don't show up.
Okay, thank you very much. One more clarification question.
Thank you, Dr. Sanhueso, for an excellent presentation. That was very informative. My question is related to if the medical abortion, the drugs are available in pharmacies, do we know how much linkage or if that is actually happening when it comes to women being able to access, coming to Mexico City and buy the medications, or through the black market be able to get those medications? Would we know the percentage or proportion of that happening?
But what is specific the question? How many pills they sell in the drugstores, and what happened? We don't know. We know we're on national TV here, so we can know some information. But I think this is a very important question. Very. What happened with the misoprostol at the beginning? Was this big, huge company, like Cytotec? That was the only one. Now it's 5. But some of them, it don't work. With the MIFE, doesn't matter. But we hope to bring more MIFE, more company to bring MIFE. The ideal scenario is to have the combo pack with the national lab, because it is mandatory. If it's a national lab produce the MIFE and the MISO, the government has to buy it. Because in India, we know that India and China is so inexpensive, or less expensive. So that in Mexico is still, that happened with the price of the MIFE. At the beginning was $60 every pill. And then came the other company, they dropped the price to $15 a pill. And then they raised the price to $50 a pill. So you say, but how much is it going to cost the MIFE, We know this very, very, $1 or $2 in India. I don't know how much the combo pack costs, $5. In the United States, more expensive. No?
Yeah, just hold your horse, Madam. I think we will have some time, so maybe let's just give the other presenter a chance, and then I'll definitely start with you. The question and answer session. So the next speaker is, again, with us virtually. This is Dr. John Muganda. Muganda is working in the Ministry of Health in Rwanda. He's a medical doctor, and he's serving in the All-Skynet department. Muganda has also an equally long experience in working on reproductive health. I hope Muganda is on the line and he can actually start his presentation. Please, Muganda, you have the floor.
Thank you for allowing me to share with you the Rwandans on post-abortion care and discuss on issues around stigma in the context of that program. I am speaking on behalf of the Rwanda Ministry of Health and the Rwanda Society of Obstetrician and Gynecology. In Rwanda, we don't have many studies which have been conducted on abortion, but let's share some figures from Great Macha Institute, where in 2009 we had abortion per 1,000 women 15 to 49 years or 25, and abortion per 100 live births 13.9, number of induced abortions 60,276, and women treated for complications of induced abortion 16,748. Next slide. As you see on this slide, 1/3 of women with abortion complications did not receive care in 2009. In treated complications, 11.7%. Next. On the following slide, nearly half of all pregnancy in Rwanda are unintended. We have unintended pregnancy, birth and miscarriage, 37%, and unintended pregnancy induced abortion, 10%. Around 47% are unintended pregnancy. Before we look on the next slide, on the Rwanda Penal Code of 2012, already since February 2012, we had a comprehensive post-abortion care program, and beyond, and from that program, the Rwanda Penal Code just came to reinforce the existing program, which really had success. And with the Penal Code of 2012, we had the ground on which abortion is permitted, which existed before. It is when pregnancy jeopardized the health of unborn baby and that of pregnant women. But with the new, with the Penal Code of 2012, it had been, we had other exemptions where pregnancy is a result of rape, and as we define, under 18, it is also a case of rape. Pregnancy as a result of incest up to second degree, and pregnancy as a result of forced marriage. So the Penal Code just came to reinforce the existing program. As I said, the existing program, which started in 2012 in February, now we have a national comprehensive treatment protocol. We have a trainer guide, reference manual, all tools needed to conduct a program. Let's share as a summary of the PAC program in Rwanda. the phase one from February to October 2012, misoprostol have been introduced as a treatment of incomplete abortion and miscarriage. And from that time, we had 7 health facilities providing the PAC program, and it has been expanded from 7 to 55 health facilities. And the phase 2, from May to October 2013, the phase 1 have been, the MV have been integrated in the existing protocol. Before it was misoprostol, which was the medical method, and MVA have been introduced as a surgical method. And additional activities to strengthen post-abortion family planning also have been added, and we started activities of monitoring and data collection. On the next slide, really, we can try to see how things have been changed in the country. Before, quite 100% of incomplete abortion and miscarriage were managed at the hospital level at the beginning of 2012 in February. But when you observe in October 2012, the vast majority of incomplete abortion and miscarriage were managed at the health level, which is very, very important because it brought them closer to women. As a result and impact of the PAC program, on the next slide, this program increased the availability of PAC services and brought PAC services closer to women. Treatment with misoprostol was safe, effective, and most commonly used method, and which again is very important. Mid-level providers at health centers successfully provided PAC services. The program is currently being scaled up nationwide with the collaboration of Ministry of Health and partners. And as we had a penal code of 2012, now currently we are doing operationalization of exemption for abortion. So in that program, now we have the guidance document, we have a national protocol and a trainer guide. In the next slide, about abortion stigma in the context of Rwanda, there has been no formal study of abortion stigma in Rwanda, but the ongoing work on the operationalization of the penal code of 2012 included interviews with key informants and focus group discussions with women, which showed some light on perception on abortion and stigma in the country. On the focus group, young women may commit suicide due to the shame of unwanted pregnancy. We had one who declared that youth should be informed that some girls who commit suicide because of unwanted pregnancy, they should be informed that there are exemptions. Which again have been found in focus group discussion. Abortion is still considered as a sin by many, even if the pregnancy is a result of rape or incest or endangers a woman's life. One declared that due to my religious belief, I will not accept any abortion because it is a sin. It is killing. Another thing is what we found on baseline assessment on key format interview, where providers' negative attitude towards abortion can be a barrier for the operationalization of the penal code of 2012. It reveals that doctors being part of the Rwandan society are still in the same confusion as the rest of Rwandan society due to the culture for some and religions for others. Some doctors are not supportive of the new provision and some don't have the skills to perform an abortion. that they need to be trained as key actors. Due to abortion-related stigma and cultural sensitivity, cases of pregnancies due to rape and incest are kept confidential. What we found in the same baseline assessment, the sensitivity of abortion in Rwanda's culturally conservative environment is important because no one wants to be known that they were raped. In case of incest, family members tend to hide it. Another thing we should know is that the court order required can make access to safe abortion very challenging. If you are raped and you come to a situation where you want an abortion, it will be very difficult to start the process of presenting your case to the court and then to the medical doctor, who will also have to give their approval, bearing in mind that we don't have enough doctors. People will keep on going to other countries where abortion is legal, or as they will prefer to do instead abortion. On the next slide, other issue related to abortion stigma in Rwanda. Abortion is still criminalized in Rwanda, which perpetuates the stigma even for legal abortion. Gender-based violence, GBV, prevention and management services were established before the Penal Code of 2012 and do not include any information on legal availability of abortion. At GBV centers, women are counseled to accept the pregnancy. Within the PAC context, all women present a miscarriage, making post-abortion contraception service challenging. Lack of clear guidelines for the practice of consensus objection may prevent women from accessing safe abortion services within the legal framework. The stigmatized environment makes it difficult to collect accurate data on unsafe abortion or legal safe abortion. In conclusion, thinking into future, Ministry of Health is committed for implementing the legal framework for safe abortion. Support from the stakeholders is strong. Ongoing work on operationalization of Penal Code of 2012 will provide further information on data on the current status of legal abortion services. We are planning to disseminate, to have a disseminating meeting in February next year, 2015. Further community involvement is key to address stigma. Gender-based violence, GBV, management service provides important opportunities to work around stigma. Young women should be prioritized as they are commonly victims of GBV, and any further work with potential partners to understand and address stigma is welcome, and I thank you.
Thank you very much.
Thank you.
So please hold on. Directing some questions to you. But just to start, I want you to just think about, I had the previous, if you were also online, I had the previous speaker mentioning doctors and OBGYNs being reluctant to provide services. Is there an aspect of stigma around the doctors and OBGYNs? Because I know that is what we normally do when we feel we will not be part of the larger community of our colleagues and friends. So how much is that playing around in influencing the doctors and some of the nurses in providing those services? think about it and maybe you'll answer much later. I think I'll start with the lady behind there who addressed.
Hi, my name is Jamila Taylor and I work for IPAC based here in Washington. So my question was really for the gentleman that we had before this last presentation about Mexico City. And I wanted to know if you could share more about what was happening in terms of outreach to low-income women and young women in particular, making sure that they know what the law is in Mexico City, as well as making sure that they know where they can get access to safe abortion care as well as contraception.
I'm sorry, but I didn't catch. Do you know more details about why is that difference, or what is the strategy for try to not happen in the near future?
I guess my question was more about what is the strategy, what sort of mechanisms or activities are in place to make sure that particularly women and young women at the margins know where they can access services.
Okay, exactly. That was something this is very important, because in the beginning, I mean, remember, we are the government. We offer service for free. We didn't think maybe that it was necessary to show up what happened and what type of services we offer, because we don't do that for pregnant women, we don't do for anything. They just show up without no appointment. But after that difference that we noticed, I think maybe, for example, for breast cancer, we do a campaign in October, very important, so to try to call the attention for women to go to the mammography and all the service that we have. So now we are working on it. We are working on where we, specifically in the segment or the type. Okay, we know how they go to the service because they use internet. If they use internet, in most of the cases, even if they are very, very poor, for 1 peso with very little money, they go to the cafe internet and they know the information. So we have to break barriers to go where to go, what are the requirements to do it very easily for all of them. So we need a very good web page, very easy for young people, because we are working on it. We need to describe geographically where to go very easily, what's a train station or metro station they have to use. We have to, in different segments of the government, for example, the financial secretary, the people who work in some other part of the government, try to spread the news about the services, but not just that, about the vaccine of the H1 and N9 in winter, everything. Not just go with one product because it could be a contraception. So we are working on it. We are working with young people. We are working in internet. Do you know La Alianza in Mexico? It's a group of NGOs who work with equity and gender, HIRE, IPAS, Catholic for the Right to Decide. So we use different material of them. So we already know this is a need. Maybe we were too old-fashioned or too conservative, and we didn't say anything. But now that the private sector is offering a lot of different options, sometimes we think, but why we offer so many things for free to the women? They don't came to us. Not because we are jealous, but I think the government has the responsibility. No, in a way, I mean, the government has the responsibility. We have the implant for free. Who can compete with us? We have the best provider. It's not because I work for the government, but it's true. And it's part of the collaboration of all of the NGO. They know how to use the medicine perfectly. They know how to use medical aspiration, electrical aspiration. We have beautiful clinics. The service is quick. In less than 3 hours, they have the lab, the ultrasound. The counseling is very balanced. We don't push nobody to do the procedure. Sometimes, and it's quite a huge number of women decide to go with the pregnancy because depend on the relationship with their partner sometimes. You know, they are 20 years old, sometimes they like to be married, and if the guy goes back and they say, oh, maybe this is another chance, they decided to have the baby. We don't know. You know, so we offer always those three options about in the counseling. We not push. We are not pushing, and even the minister say, well, maybe we have to be more proactive on that, and also like waiting for the women, but try to help to share the information with, especially with the poor people. I think they are the more vulnerable.
Yeah, thank you very much. I think that is quite a critical issue in terms of having access, but people voting by their feet, not coming to you. Sometimes it's an aspect of empowerment, but sometimes it's also, there could be some inherent issues around quality or some other issue that really one needs to drill down and get to them and address them with community participation. But if you offer them all what you are saying, actually, which I think you're right, there should be some other aspect that maybe is not working appropriately for the poor and those who actually, vulnerable groups that need really the services that are. Now, I would just request that we, those who have questions for Nepal, to come forth because right now, if Indira is still with us, it's going to 11 p.m. So I think just to be conscious of that. Do we have any questions for the speaker from Nepal? I see none. Indira, are you still on line?
She is.
Hello, Indira.
Yes, yes.
Still online. Actually, I just want to express our gratitude. We were very impressed with your presentation. We don't have a question directed to you, so just feel free to stay with us or, leave at your own.
Okay, thank you, thank you, thank you so much. Thank you.
Okay, Madam. Okay, so you are going up.
Yes, my name is Stephen Gwere. I work with Infrahealth on the E2A project. My question is for Dr. Muganda from Rwanda. I think everything now goes because
Shant with us?
Yes, yes.
If you hear the question, can you tell me?
No, I didn't catch the question.
Yeah, I think sorry about that. We had a question that was directed to you. Basically, around the penal code that has person interested in the mechanism that put in place they don't end up
So the question is about the penal code.
Yes.
And they're asking what is the mechanism being put in place to implement.
Yes.
Okay. So really, we have the penal code, which precise exemptions for abortion, and we worked with all stakeholders, healthcare providers, police, the Ministry of Health, the Ministry of Justice, and we discussed and we put together the way of working and the strategy to try to know exactly how we can hurry things because if even we have to terminate pregnancy, there is an age of pregnancy, we have by doing it early, it is the best time. So they are aware of all those things, and the only problem it will be just to try to give the court order on time, and then and give services to those who need care. So we are starting. We have many challenges, but I think with time we'll try to know what is other barriers we didn't even think about, or if we are just starting with the program. So I think with the restitution, the meeting which is planned for next year in February, we'll try again to discuss and know what we can improve to succeed the program.
Okay, thank you very much. Education. Community. Otherwise, why does it not understand that decision an equal part?
This is Katie. And I just want to something we say out written laws Lydia and another here. Abortion is under stigma such as sexual violence or rape. A victim so that developing implementation plans with partners, we need to procedures for compassionate something that sometimes is what we're working with law enforcement. But I think really good.
Thank you very I hope John in Uganda started issues but there are tools that could be used to address the stigma around 2 or 3, like the sexual violence that was mentioned and issues related to abortion, etc. Sometimes even HIV/AIDS. Yes.
This is Maria Hodolikin from ASAC. First of all, thank you very much for the excellent 3 presentations from countries. They were very informative. I just want to add a few comments to Dr. John Muganda's presentation. I have been working with him and with the Ministry of Health. So just a few things to add to what he said is the operationalization of the Penal Code of 2012 is still in the making in Rwanda, and it has different components. One component is community awareness. There have been meetings in country with all of the stakeholders that Dr. John mentioned, from the police, gender-based violence services, also UNICEF, which is their gender ministry, Ministry of Justice, even to prepare an IEC material that can be used by community leaders to inform women that this is now their right. But it has a lot of, intricacies. How do you position it in terms of what is the best way to tell women? Like if you're raped now and if you don't want to keep your pregnancy, now you can have a legal abortion. We can say it's straightforward like this, but within the community it requires many different approaches. And there are other partners in country that are also working with young women to address that. And training of the providers definitely is, there has been a training including the values clarification and attitude transformation, but there needs to be more. And conscientious objection, as Dr. John mentioned in his presentation, has not been clarified yet. What could be the cases that it can be, that's right, if it's defined as a right in that sense, can be exercised, whereas in some cases maybe if it's emergency, then maybe the woman needs to be, her life needs to be saved regardless of what the doctor might be thinking. So there are many different things, and data collection is going on from the courts to find out how many women actually applied for a court order and how many women were able to get a court order. So we will see that coming, and also from the health facilities about legal provision of legal abortion. And the more you look into it, the more questions you have. It's that kind of a situation. But I think the Ministry of Health should be commended for their commitment to address unsafe abortion, starting first with PAC and now moving into taking full advantage of their penal code right now. Even though it may seem restrictive, still, it's a very important step in the process.
Thank you very much, Nuria. I think, do you have a burning question, because we are run out of time, but please go ahead.
It's not that burning. Okay.
Just put it on fire, please. Please go ahead. We'll allow you.
Yeah, sorry. Okay, so I'm keeping them from lunch. My name is Callie Simon. I'm with Pathfinder International. Thanks for the excellent presentations. And I was going to make kind of an observation, and if the panelists had a commentary, I welcome it, but perhaps we can even leave it as something to think a bit more about. I'm not sure how many of you have read the World Health Organization's State of Adolescent Health report that came out, but self-harm is now the #1 cause of adolescent deaths among females 15 to 19 globally. And that for me was a huge shock. I work in adolescent health, and frankly, it really surprised me. And in my mind, all of the references, though anecdotal, that we've heard this morning to young women thinking about or actually committing suicide as related to stigma of unintended pregnancy or gender-based violence and not being able to access abortion or seeking abortion and all of that, it sort of is, it's jiving in my mind, and I'm thinking to myself that we probably, this deserves more investigation. We've heard a lot of anecdotes today. They are just that, anecdotes. But that paired with this alarming evidence of global deaths among 15 to 19-year-olds due to self-harm deserves further inquiry, I think. And so I wondered if anyone here has had a chance to do such further inquiry, if we know more than just anecdotes yet, or if we could in the future think about some further investigation into this area of intersection. Thank you.
Thank you very much. That was a call, and we'll probably certainly we'll have a session towards the end for some discussion, and I think adolescent health is one of the aspects, and stigma and whatever. But I think mental health and adolescent health, there was a study, I think it was reported by UNFPA, it's pretty dated, but looking at what the expectations were, they were completely parallel to what health workers normally think about, what adolescents need. And in terms of problems, I think mental health was by then still the top, issue that was going most of the time unnoticed. And so this is not very surprising, but it is, a very serious issue that we need to discuss. Now, I think we have run out of time, and I would like to recognize our timekeeper who has actually kept us on track and is doing it very quietly behind there. It's only me and maybe the others here who can see him. Ricky, thanks very much for that. And all the other speakers who are on virtual, I would wish to thank you very much. It's now lunch. Where is lunch, Chris? Maybe. Yeah, lunch is just outside. So I think I understand it's a working lunch. We are still going to have a session that updates from the task forces. So we would encourage you to, pick your food, come back, and try and be relaxed and have your food as you enjoy the discussion. Thank you very much.
Yeah. And I just want to thank all of you who managed to stick through us through some of the technical difficulties this morning. We really appreciate it. A recording of this will be on the PAC Consortium next week, along with all of the slides and some additional information that will be on the website, and will be sent out to the PAC Consortium list. So thank you all. I know some of you are very late in your evening, so thanks again, and we look forward to participating in another webinar with you soon. Yeah, we'll just kind of figure it out.